Hello and welcome back to another week of Ask Alex. We got unconventional this week, and Preston and I decided to sit down and quiz each other on what different phrases doctors and patients use so that as a provider and as a patient, we can understand each other a little bit better and avoid more of those misses where it feels like you're just two birds, two boats floating by each other. You know the saying I'm trying to say. Without further ado, because clearly I need another coffee, I hope you enjoy the translation section that Preston and I put together for y'all, and I'll see you next week. There are things that will muddy up the waters in communicating with patients and providers. And I know we talked a little bit about this when I came onto your podcast, and we said, patient speak, doctor speak. What the hell are we talking about? There's a few things that providers say that I think sound very scary as a patient, and I wanted to ask you what they actually mean.
Okay.
The first one is when a doctor writes down non-compliant on a piece of paper. How bad is that?
Non-compliant?
For instance, when I went on high-dose prednisone, I had a resident tell me I needed to go on antibiotics. And I said, no, I'm not doing that.
And then they wrote that you were non-compliant.
Yeah, they were like, that's really risky. You could get an infection and it could be really serious. And I was like, I totally hear you. I've been on and off prednisone my entire life. I think the risk of taking antibiotics prophylactically for the next year and a half is not worth the reward because it will fuck up my gut, which then has worse effects on my autoimmune disease.
And they wrote this on your note, or they just put on a sticky note and like slapped it on your forehead?
They wrote it on my fucking face. It was so,
God.
It was just rude.
We haven't done that since the 90s.
I know.
That's old-fashioned medicine.
It was. A youngster trying to mimic.
He's just stuck in his old ways. The non-compliance has an air of oppositional
It does.
subliminal messaging to it. And there are certain ways that you can describe non-compliance that may be more dignifying. I think some people will say patient has elected against medical advice not to use antibiotics. That could be like a softer way to say it. Some people disagree with this and say, well, just saying non-compliance is ultimately what's happening. The patient's not being compliant with the recommended treatment.
It's true.
And while that's true, it does carry like some amount of weight to it. And people see in old notes that a patient has been non-compliant. They assume they're going to be non-compliant again.
That
Or they assume that they're going to be like oppositional.
feisty.
Yeah. Disagreeable with the team ultimately.
Yep.
So non-compliant can be a way to signal that. That being said, I still write that patients have been non-compliant. I usually, put it in different ways. I'm not saying the patient is non-compliant. I might say the patient has struggled with compliance with their medication regimen.
Ah, okay. Like taking it normally.
Yeah. So
Okay.
they come to me. I've been taking my Lexapro once a week.
You're like, ooh,
I would
that's
say,
not how you're supposed to do that.
So I'll say they've been struggling with compliance. I've had other attendees that write that they're vulnerable to non-compliance.
Oh, that's
with medicine.
interesting.
Yeah.
Huh.
It's almost like it's something that happens to them.
It's I get why it's used. And then from the patient perspective, I'm like, I get why we hate seeing it. Because to me, I'm like, I just was saying that's not, yes, that's the right direction for most people, but for my body, no.
The other option is like non-adherent.
I like that so much more.
Tell me about that. Why does non-adherent sound better than non-compliant?
Because compliant means that somebody else is getting to have the final decision on what I'm supposed to be doing with my body instead of a conversation team decision on like what's best for me specifically.
I would agree with that.
Yes.
I'm proud.
Thanks, Preston.
Yeah. Like I can adhere to my diet plan.
Yes.
Because it's between me and myself
Exactly.
and it's really about sticking to it. But complying, has like an obedience flair to it.
Yeah.
Like imagine if I put the patient as disobedient.
Would be so fucking weird.
Yeah. So
that's how it comes across.
Is a better thing. And actually, thinking about it now, I may use non-compliant and non-adherent almost synonymously, and maybe I should just completely replace it with non-adherent.
Did I just change medicine forever?
You did, at least for my notes.
Just doing the Lord's work. One of his chosen ones.
Okay, one down, non-compliant.
Next one. This is my favorite one. AMA, not social media AMA.
Ask me anything.
Ask me anything, which is what
advice.
my uncle thought when I put on my Instagram story, hey guys, AMA. And he called both of my parents and was like, what is Alexandra doing? This is not good. Against medical advice.
Yeah. So that one does have a stigma. I also don't know if there's a way around it because that has a lot of legal weight. So if a patient is not safe to be discharged, the hospital is basically saying we do not want
liability.
Like we agree that you have capacity to make whatever decision you want and you're leaving against medical advice. I think you can add more context to it.
Mm-hmm.
So patient elected to leave against medical advice due to, concerns about making a really important event on time. Like there's like once in a lifetime event, like you're seeing your daughter getting married.
Yeah.
And there's a risk of you, I guess, going off of IV antibiotics 2 days early to switch to oral. Like the whole team says you should stay on IV for a couple more days. And you're like, if I stay here for 48 more hours, I'm going to miss my daughter's wedding. It's not worth it.
Yeah.
So then you can like add all that context to the note instead of just patient left AMA.
I like that. I think that adds the context that when you're a patient reading the notes, because I don't know, do providers think that patients read the notes?
Mm-hmm.
Okay, well, never mind then.
I think sometimes they almost want, some providers use it as their like final way to like get back. Like, I told you not telling you and you did it anyways.
I have seen that in my notes before. Only from one person. They're on my list.
They're on your prednisone list.
Yeah, they don't get nice, amenable Alex.
I think you can also phrase it as like, they were like requesting discharge and like we adjusted their plan.
I like that.
So it doesn't have like there's a threshold. Like once it is against medical advice, like cat's out of the bag. But not everything has to be against medical advice because you can change the medical advice. And this is obviously very unique to each situation.
True.
Ultimately, the doctor could say, well, maybe we could switch to PO antibiotics now. I'm not in that position. I don't know what it is for that patient, but it's really the kind of the call. And it's all a risk-benefit analysis.
Right.
And it just depends on like how much the provider is willing to adjust their tolerance of risk with the patient, like put their name on it. So there is like middle ground to being able to like help accommodate the patient's needs without just immediately saying like you either do what I'm saying or it's AMA. There's a lot more gray area before you reach the AMA threshold. So to answer your question, what does it mean? Well, it ultimately means the patient left without working with the team,
mm-hmm.
but that's both a reflection of how much the patient was willing to work with the team and how much the team was willing to work with the patient.
Agreed. And I think that's the important asterisk.
Mm-hmm.
More often than not, I think patients read it and they're like, well, they think it's just me, but they weren't willing to meet me where I was trying to go.
Yeah.
Bidirectional. I like that. Okay, your last one from the provider perspective. It's just anxiety. It's just depression. It's just blah-de-da-de-da.
Mm-hmm. And you're asking me specifically as a psychiatrist.
Well, I guess I should caveat. I mean, when providers say it's just blank and it like plays down whatever it's going on. Mm-hmm. Well, you broke your toe, but it's just a toe.
It's just complacent in general to ever say it's just X.
I agree.
Even if, because let's think about it the other way, right? Let's say you have brain cancer and you are having panic attacks all day long and you're freaking out about what's going on.
Yeah.
And you're even hallucinating a little bit or you're dissociating with these panic attacks. And I go, oh, well, your tumor is pressing on your amygdala. So actually, it's all just your brain cancer. And you're like, dude, I'm anxious. Like, I swear to God. And I'm like, well, it's just you're going to feel it this way because it's just your cancer going on. How would you feel in that situation?
Terrible.
And like ultimately the problem's not solved.
So playing down of anything.
Yeah. And I think the best way to approach that is, even without this tumor pressing on your amygdala, it could be anywhere in your body, you're probably still going to experience anxiety. So I would
it's massively exacerbated right now.
So I think how I try to frame it is, whatever's happening, you're experiencing this symptom, period. And it may be coming from, it's probably a combination of like your brain tumor pressing on the amygdala, and also you feeling anxious about the uncertainty of your situation, the terminality of the diagnosis, your history of cancer in your family. It's probably all contributing to this.
I love
so
that
ultimately we can
explanation.
figure out, and then I'll usually say, it could be this, could be this, could be this. And then I come back and say, it's probably a little bit of all of them. Who knows?
Now you get the gold star.
And then I say, let's focus on actually treating it so you
Yeah.
feel better, because we can opine until the cows come home as
About
to
why.
what is the true source of your anxiety, or we can start you on Lexapro.
And Lexapro rocks.
I like Lexapro.
Me too. That's what I went on after I got kidnapped. That and lorazepam.
Nice.
Had no idea what lorazepam was, but I was like,
right there.
damn, this stuff makes me not feel like someone's gonna attack me in the middle of the night.
Stuff makes me not feel anything.
Great. Okay. For providers, are there anything that patients say that you think sound a certain way, but maybe I could have a different perspective on? I wrote down a couple ideas in case you didn't.
Did we talk about this last time, or maybe we just talked about this offline? But the high pain tolerance.
Yeah.
one.
Oh, yeah.
Well, we talked about it on our podcast.
We talked about it on your podcast.
Yeah. I think when patients say that I have a high pain tolerance, they're trying to signal to the provider that they are suffering and they have endured a lot.
Yep. Full agree.
When providers hear the patient say, I have a high pain tolerance, it automatically starts the heuristic or the assumption that they are, number one, not going to have a high pain tolerance, and number two, going to end up being drug seeking in some way.
Yep. Totally agree.
Like they're telling me I have a high pain tolerance, so it's a way to say I have this much amount of pain, and then
This
they're
would make it make
going to
sense.
ask for pain meds afterwards. These are obviously huge blanket statements.
Yes.
But if we're talking within those stereotypes, this is kind of how the high pain tolerance is seen almost as a meme on the medical side.
When we had that conversation, I stopped saying I have a high pain tolerance in the ER and started saying I have endured a lot of pain. I can sit through it, but I have a very low pain tolerance. I have a hypersensitivity to a lot of pain. So what I'm experiencing right now is terrible, but I'm not crying on the floor right now because I can endure it for a long time.
Yeah. And have you noticed a difference in how
Been
people
so
affect
much
you
better.
or treat you? Yeah.
So much better.
Wow.
They're like, oh, and you know what? In that terrible hospitalization where I had aseptic meningitis again pretty recently, the provider came in and he was like, so how's your pain being handled? And I was like, not great. And they were like, okay, well, we can give you some Tylenol. And I was like, that's not super going to help me a lot, but sure. And then the attending came back in and talked to me and was like, hey, why don't you think Tylenol is going to help you? And I got to have a really nice conversation with him about saying, this is what I'm usually offered. Here's what my pain tolerance is like. Here's what I take. This is what I think I need. But I know if I say any of those things, it makes you think X, Y, Z. That makes me have anxiety. I look like I'm not in pain. So I know everyone thinks Tylenol is probably enough. But here's what my experience has been. And he was like, thank you so much for explaining it to me like that. It's never happened to me before.
And you're effectively saying the same thing you were saying before when you said I have a high pain tolerance.
Yeah.
You're just using different words that don't trigger the stereotype.
Yep.
From their perspective.
And there's the acting.
It's all theater.
It's all theater.
Really. The reason why we offer Tylenol first, even if it's a lot, is because we want to use a laddered approach to pain management.
Yep.
So I think patients and providers can get stuck in these circles where the patient says, I don't even want to try Tylenol because I know I need something stronger. And the doctor's thinking, well, if you're in so much pain, why are you rejecting Tylenol that might even help a little bit?
Yep.
If you were in that much pain, shouldn't you be willing to take anything that could possibly help with your pain? And that's the back and forth where they get stuck and they say, well, Tylenol's not going to be helpful. I want something strong. And you're like, okay, well, we'll give you a graduated regimen. But if you're not even willing to try Tylenol, why would I give you something heavier?
And I think from the patient perspective, this is a huge waste of time for us to go back and forth up this ladder. Let's say it's endometriosis flaring.
Yeah.
And
Why would I wait 3 hours
to
tell you the Tylenol's not working when I can tell you right now it won't work?
Exactly. Or I've been taking Tylenol for the last week. That's why I'm here. It's not touching it.
But I get the reason why providers do the latter, and I also understand the intolerance for being like, that's not an acceptable first line of defense if I'm saying no.
So what's the solution to this?
I think it's a conversation of hi, you are reporting this kind of pain. What do you usually do with this kind of pain? And it's a curiosity from the provider instead of I know best, here's the ladder that we always use for every single patient, blah, 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 blah. And it's instead patient specific, biospecific, not here's the textbook, here's step 2.
I think that would be a helpful approach.
I think so too.
I also think that it ends up almost being a negotiation.
It does become a negotiation.
I'll give you your regimen, and you also show me like that. I'll show you that I'm willing to work with you, and you, even if you think it's not going to help, accept the Tylenol because it shows you're willing to work with the team.
Yes.
Because if ultimately, if you add Tylenol into your regimen, even if it's not normally a part of it, that should be somewhat helpful.
It should do something.
Right. Yeah.
But also if you're having like endo labor level pain, will it touch the pain to a point where you notice it? Probably not.
And it may not.
It probably will.
And also, it shouldn't hurt you.
True. It shouldn't hurt you.
So I think that's how the physician sees like what's the harm in taking a little like Tylenol. So that it's like, okay, like I guess if I was a patient, I'd say, yeah, I'm willing to try the Tylenol, and already I'm in so much pain, I don't think Tylenol's going to touch it. Let's start with that. But then can I get something else right now too?
Yes.
Kind of. And that's how you guys negotiate that kind of like contractual back and forth.
I think that's really wise. That's actually really wise advice. It's the yes and.
Yeah, I guess to go back to the theater analogy, it's improv. You need a yes and not no but.
It's all
like,
just theater,
yes,
baby.
You're offering me Tylenol, and can I please have my home regimen?
Feels like I am getting electrocuted in my uterus right now. And Tylenol doesn't help with electrocution. And then you get somewhere.
Yeah.
I like that. What do you think? What do you feel when someone says, I Googled? And can you tell when they have actually Googled and read like an NIH paper versus I Googled and I read and they mean one square on Instagram? Because I use those interchangeably sometimes.
So that can lead to different things. There's I Googled and I have a question about this. I'll give you an example. I'm going into fellowship in neuropsychiatry, so I do a lot of clinics with patients that have neurodegenerative disorders, and Alzheimer's is a very common one that falls under that. It's like the most common form of dementia we have.
Yeah.
So there's this study that came out, a Harvard hard science paper on using lithium orate to break apart the plaques associated with Alzheimer's in rats. So people come in and they say, should I start dosing lithium because of this lithium orate study? And so that initially starts out as I Googled.
Yeah, it does.
Right? So a lot of patients bring that up saying like, here's something I found interesting, but ultimately I want your opinion as a doctor on it.
That's what I do.
And then that actually ends up being a good conversation where I say, yeah, like, we blast these rats with lithium and it helps with the plaques. However, we already have medicines that take away all the plaques associated with Alzheimer's, like lecanemab, and that doesn't stop the progression of Alzheimer's. Lithium, while it stabilizes your mood, and bipolar has other possibly neurotoxic effects if you take it for something we don't know it's helpful for. Yeah. So then what I end up saying is there's a possibility that it might help, but we don't have enough evidence to know that the benefits outweigh the risks at this time, so we're not recommending it to anyone.
I love that. I like that you engage with the question and the research that a patient's bringing to you.
Because if I don't engage with it, like, then ultimately it kind of makes them want to investigate it more, and that's not how you have a good discourse with someone.
Totally agree with you.
There's the other I Googled, which is I've Googled my symptoms. I know I have autism. There's no way this is a personality structure issue, and I've made up my mind.
Yep.
I know I have autism and ADHD, so just give me my stimulants and I'll go on with it. That becomes really frustrating because even in psychiatry, the only tools you really have are your observations of the patient's behavior and their affect, and also like the report to it, and then possibly like collateral information. So if you have come to the conclusion that you have all these disorders and I try to ask you questions about your symptoms, you're going to be filtering everything to tell me in a certain way what you think you should have.
100%. People do this in rheumatology, in the autoimmune space.
Yeah.
They'll DM me, hey, I am trying to pursue a vasculitis diagnosis. And that DM scares the shit out of me, because how would you possibly know that you have vasculitis? Do you think you're autoimmune? Yes, but you can't know what autoimmune type you have without any kind of testing.
So yeah, it's like, and I think in that context, the patient has played the doctor themselves, and then they see the doctor putting the diagnosis on their chart as a formality that they just have to get past.
Yes.
That's the I Googled that stresses me out.
Me too. Really, it stresses me out a lot.
Because
yes, we know our bodies, but we don't know medicine.
Yeah. Well, like me going to the mechanic and telling them I know my car.
Yeah. Like, yeah, you know how your car's supposed to feel. You know the sound it's supposed to make. You know certain things about it, but you couldn't tell. Maybe you can. I don't know if you're a gearhead.
No,
you couldn't tell if it was, and this is how you're going to know I'm not a gearhead, something in the gas casket or the hood of the car.
Yeah, or the catalytic converter.
Hey, that sounds right.
Or the belt.
Or the heart.
I wouldn't be able to know any of those things. And the thing is, like, even people in medicine have trouble differentiating those. Like, it's really complicated.
It's really complicated. They're multi-system. And how are you supposed to strip symptoms apart by yourself without current scientific...
It's hard for doctors because you want to validate that a lot of their symptoms that they have might be consistent with autism, and they also might be consistent with other disorders that impair people from socializing properly. And
so how do you navigate that as a provider?
In short, I don't know. Mostly what I try to do is just reinforce like our relationship and get them to the point of like trusting me enough to like offer an alternative solution. So the first patient that we talked about is relatively undifferentiated. So it's more so like I can guide them with my opinion. They're bringing something up. But that second patient who's already determined what diagnosis they have, you have to like undo thinking and then introduce new other options. That takes a lot longer. And for them to even consider undoing thinking about something, you have to know them for a long time. They have to really trust you. So I guess the way I navigate is I don't even try to challenge it at the beginning. I just kind of, I'm supportive. I talk openly about them, and then I try to validate as much as I can, and then plant seeds about other things that might be helpful. Like, hey, you know, like we've been doing this treatment for a while, and I'm noticing you're not necessarily getting better. It makes me wonder if there's something we're missing. This could be
so many other things.
Else. Yeah.
Let's investigate more.
There might be more effective therapies for you.
I love that. I think that's probably harder to do in like rheumatology medicine.
Yeah.
Than
much harder.
Psychiatry. But that same approach of meeting the patient with could be that. But also I've been taking a look at things, and I think it could be something else would go a long way. Because especially when patients come in at that point, they're operating at a place of fear and anxiety. When I like post getting COVID, I had all these really, really weird dysautonomia symptoms. My resting heart rate was 125. And if I just walked around my kitchen, it'd go up to 201. It was so stressful, very uncomfortable. And then all of a sudden it dropped to the 40s as a resting heart rate. And I was like, do I need a pacemaker? Like, what is going on? And I got it so stuck in my head that I was going to need a pacemaker. And so when I saw a provider, I was like, hey, this is what I need. This is what's happening. When should we get this scheduled? And he was like, I totally hear you. We're going to do some testing. I don't think you need a pacemaker. And I remember being really, really frustrated with him for not agreeing with me. And then over time, I got fatigued by just like pursuing this, that I stopped doing anything. And then over that time, things normalized again. And I was like, fuck.
He was right.
He was right. Damn it.
There's a saying that the truth will set you free, but first it's going to piss you off.
I like that saying. Damn, it's true.
It is.
And that's a wrap. Thank you so much for joining me for another week of Calling in Sick. As a reminder, I would love for y'all to like, follow, subscribe, save, share with a friend, do all of the things. It truly helps grow this community, and it helps these episodes reach the people that need them the most, whether that's for an educational piece, to have a little laugh, or to not feel so alone. As a reminder, Calling in Sick sits on YouTube, Apple, and Spotify, and anywhere else where you can find your listens. From the bottom of my heart, I absolutely love you guys. Thank you so much for calling in sick with me every Monday. It's been an honor and a pleasure so far, and I can't wait to continue building this community with y'all. Love you.